Is Dr. Karti here yet? Or
I think he will join soon. I just in 5 minutes he'll join. Yeah.
if he can join before we start, so we can check with him about screen sharing, that will be nice.
Kati, உங்க பேர் வரவே இல்லை. Where are you?
Dr. Abuzar,
Yeah.
I think it's almost time. You can,
Okay.
you
I
can
think
start, I think.
join probably. We can start the lecture and probably he'll join in the meantime.
Okay, so Dr. Abuzar, you can start introducing Dr. Vinod and say welcome to attendance. You are muted, Dr. Abuzar.
Welcome all participants and the lecture. Today we will talk about the middle cranial base, and also we are lucky to have the ENT surgeons and skull base surgeons. And these meetings organized with the Yemen Neurosurgical Society, Pakistan Neurosurgical Society, and also Walter Dendy Association and the World Federation of Neurosurgical Society, and also Young Neurosurgeons Forum and the Neurosurgical course. It's a good collaborations, and we have important lectures today. We will start with the Professor Vinod Felix. He will talk about the anatomy of the temporal bone and the ear. Please, Professor.
So thank you, moderator, and good evening, good afternoon, good morning, depending on your time zones. It's my pleasure to be here and to address you all. So let me start with sharing my screen. I hope you are getting my screen right now.
Yes, it's perfect.
Yeah.
Yes. Sure.
So let's start with the basic anatomy. So this is the what you're seeing the temporal bone highlighted here, this image, and the different parts, the squamous part, the petromastoid part, and the tympanic part, and the two processes, the zygomatic and styloid processes. So this bone is important to the skull base surgeons because there are a lot of approaches to the skull base which is centered around this bone. You can work through the squamous bone to do a subtemporal approach or a middle fossa approach. You can work behind the mastoids to do a retrosigmoid approach. You can work through the mastoid by doing a translabyrinthine or the transcochlear approaches, or the intratemporal fossa approaches. You can work below the mastoid. So there are different approaches around the mastoids, around the temporal bone to reach the skull base. And that's why this bone is very important for the skull base surgeons. So just a glimpse of the anatomy of the ear. You have the external ear, the middle ear and inner ear, and the external and middle ear are separated by the tympanic membrane, and the middle ear houses the three ossicles, the malleus, incus, and the stapes. And the inner ear houses the labyrinth, the cochlea, and the internal aortic canal. And you're seeing the right ear. I think you're seeing my cursor there, right? Are you getting my cursor? Is my cursor visible there?
Yes, yes, we can see it.
Yeah, sure, we can see.
So that's the right ear, that you're seeing the ossicles through the tympanic membrane. It's a malleus, and that's the incus. And on the other side, this is the left ear. The left tympanic membrane has been raised and reflected. And this is the malleus. And that's the incus. And here you have the stapes. So a closer view of the same image, the left ear, the tympanic membrane has been reflected. You're seeing the malleus, incus, and this is stapes. And what you're seeing there, that is the facial nerve, the tympanic part of facial nerve. It makes a turn down like that to form the mastoid segment. And anteriorly here, there is a eustachian tube orifice, and the carotid artery comes from the neck like that, and it turns into the petrous bone to form the cochlear genu there. So you can drill this entire cochlea, and that will take you to the petrous apex. You can also work below the cochlea by doing the intracochlear approach, by drilling here without injuring the carotid or the facial nerve in this narrow window to get to the petrous apex, and thereby preserving hearing. And nowadays there are approaches through the tympanic bone, through the middle ear, where you drill this area. This is called the oval window where the stapes gets attached. This is a round window. You drill this bone there, and they will take you to the internal aortic canal. And small vestibular schwannomas can be removed through the eardrum, through the auditory canal, like that. And this is a schematic representation of the translabyrinthine approach, which I think Dr. Karthikeyan would cover better. And we have this excellent approach called the transcochlear approach, where we drill the entire mastoids, the labyrinth and the cochlea, and they'll take you to the petrous bone. The entire petrous bone is in front of you. You can even reach the other side, contralateral clivus. So this is the right ear, this is anterior, this is posterior, superior, inferior. You have the mastoids there. The mastoids has been drilled. This is the sigmoid sinus, this is the middle fossa dura, and this is the mastoid segment of facial nerve. This is the tympanic segment, and the middle ossicles has been removed. You are seeing the carotid artery there, and this is the cochlea being drilled out. And this is called the transcochlear approach. You can even reroute this entire facial nerve posteriorly by drilling open the internal aortic canal there. And once we do that, you can reach even the contralateral clivus. So this is the same thing shown in the live surgery. So just to orient you, this is the eardrum. So we have the auditory canal there, and we have drilled the mastoids also. The bone which separates the auditory canal and the mastoid, called the posterior canal wall, has been removed. So mastoid, eardrum. Now the tympanic membrane is being lifted up. You are seeing the ossicles, the malleus, incus, and stapes there. And this is the mastoid segment of facial nerve. This is the lateral semicircular canal. You have the superior canal like that, and the posterior like that. Middle fossa, sigmoid sinus. Sigmoid sinus, middle fossa, facial nerve, lateral canal, posterior canal, and the superior canal. All the canals exposed. And the middle ear, the ossicles has been removed. The cochlear has been drilled out. You can see the cochlear turns there. And this is the carotid artery. So the facial nerve, mastoid segment, tympanic segment. This is the carotid artery, the cochlear genu. And we are removing the tumor by working through the cochlea. The cochlea has been removed, and we are working into the petrous apex by working between this carotid artery and the facial nerve. So this is what we call the transcochlear approach. You can also reroute this entire facial nerve posteriorly, but once you reroute, you get a facial palsy. And it may recover to House-Brackmann's 3 if you're lucky, but sometimes it's a complete palsy. But anyway, once you drill through the cochlea, the hearing is gone. And this is the cochlear genu. This is the horizontal petrous carotid artery. So just changing the view, this is the middle fossa dura. It's a carotid artery. This, in fact, is a chordoma which has gone from the, just seeped from the clivus to the petrous bone. So we did a transnasal approach for the clival part, and the petrous part is being addressed through the mastoids. So this is what you call the transcochlear approach. Okay, let us see another example. Here we have an Ewing's sarcoma in a child, post-chemotherapy, no improvement, no response to chemotherapy. And this is a surgery. We are drilling the mastoids. So the left ear, middle fossa, sigmoid sinus, the mastoids. The ossicles are being removed now. This is the facial nerve. The facial nerve. We are now drilling to expose the facial nerve better. This is the entire facial nerve. This is the labyrinth open here. So the drill is being taken underneath the facial nerve. But here the nerve was involved by tumors. We had to sacrifice the nerve here. And that's the internal aortic canal there. It's the internal aortic canal. You're seeing the internal aortic canal there. And this is the entire petrous carotid artery. This is the cochlear genu, then that's the foramen lacerum there. So now we are putting the endoscope in, you're seeing the entire petrous carotid from the neck to the lacerum completely exposed. And down there, here you have the infratemporal fossa. That's the beauty of the transcochlear approach. So entire petrous apex and the carotid artery completely exposed. Okay, so coming back to the basic anatomy, let's see some roton pictures here. This is the temporal bone. And what is highlighted there is the squamous part, the mastoid part. This is the petrous part, tympanic bone, right? These are the parts of the temporal bone. Now this is a view from the middle fossa side, the superior view of the temporal bone. You're seeing the Meckel's cave, the V3, V2, and V1 there. That's the horizontal petrous carotid artery. Middle meningeal artery there, foramen spinosum. And so this is the GSPN running over the carotid artery. And that's the arcuate eminence. And the internal aortic canal is going to lie exactly here in this region. Okay, if this is a GSPN and arcuate eminence, the IAC would lie there. So this is the superior canal, the lateral and the posterior canals. This is the internal aortic canal, GSPN, the carotid artery. This is the middle exposed. You're seeing the malleus there, external aortic canal, the mastoid. So the concept is that once you come through the external aortic canal like that, through the middle ear, through the cochlea, you can reach the petrous apex. It's almost in the same line. And once you drill through the mastoid, the labyrinth, you can reach the CP angle. So this basically forms a concept of all your approaches. And this highlighted, this is the Meckel's cave, and you have the trigeminal depression there. And next to that, there is an elevation called the trigeminal elevation. Another depression called the meatal depression. And then the arcuate eminence. So basically, the internal auditory meatus lies between these two elevations, the arcuate eminence and the meatal, the trigeminal elevation. And lateral to the arcuate eminence, there is another small depression which is called the tegmen, mastoid and tegmen tympani, underneath which lies your mastoid and the external auditory canal and the middle ear. So just to orient you again, arcuate eminence, the meatal depression, the trigeminal elevation, the trigeminal depression. And this here is your GSPN. And in like 15-20% of cases, the carotid artery here is dehiscent. You won't have the bone covering the carotid artery. So you must be cautious when you work in this area, because sometimes the carotid artery can be dehiscent there. GSPN, the carotid artery. This is your mastoid. And the labyrinth and this is the internal aortic canal. So the cochlea is going to lie exactly there. That's the cochlea. You're seeing the cochlear turns which we saw through the ear in your transcochlear approach. So it's the cochlear turns, the internal aortic canal, the bony labyrinth, mastoid, external aortic canal, middle ear. And what you're seeing there is your eustachian tube. There's a eustachian tube. And this is your tensor tympani muscle which would run from the malleus. So tensor tympani is supplied by the mandibular nerve from there. Internal aortic. So this is classically, if you have a like, if you it resembles a letter Y like that, internal aortic canal, the eustachian tube, and your external canal. And if you have this letter Y, the cochlea would lie exactly at the junction of the letter Y there, in between these two limbs. So these are the cochlear turns. GSPN, the carotid artery. And what is also important is that the nerves. So the 7-8 nerves, they are pretty close at the fundus here. So when you are drilling the internal aortic canal, it is much more safer to drill at the porus because the nerves are far apart there, but it's pretty close here. So once you keep drilling here at the fundus, you can either injure these nerves or get into the cochlea, causing a hearing loss, or you can open the labyrinth. So that is why it is safer to drill here than here, because sometimes the middle fossa approach is usually done for cases with normal hearing. So you shouldn't be causing a hearing loss in these approaches. And that is the Bill's bar, which used to be a very important landmark for your translabyrinthine approach. But we now use the other landmarks like the superior vestibule, and now we trace it from here, from the vestibule, rather than using the Bill's bar, because once you use the Bill's bar, you can still injure the facial nerve. I think Dr. Karthikeyan would mention that better. And that is actually the petrous. You remove the petrous apex from the top, and you are seeing the 6th nerve crossing the carotid artery. So the same thing can be done through the nasal cavity also, like that. We are now going to reach the same region, this petrous bone, from the nasal cavity. Now you are seeing the things from the nasal cavity. This is a sphenoid sinus completely opened up, sphenoid sinus. This is the nasopharynx, the entire carotid artery. So once you come through the other side, the right side maxillary sinus like that, you can reach the petrous apex by working underneath this carotid artery, by working between the inferior petrosal sinus and the carotid artery. So this is inferior petrosal sinus and the carotid artery. The same thing we are going to see through the other side from the nasal cavity. So just a cadaver demo of the right maxillary sinus. We are working through the right maxillary sinus like that.
And that's
There is the sella, the cavernous carotid,
cavernous segment, the paraclavial carotid artery.
the paraclavial carotid artery is the sixth nerve there, sixth nerve. You have the inferior petrosal sinus there.
Sixth nerve.
You can work into the petrous apex like that, and you are seeing the internal outer canal there. That's 7, 8 nerves and the ICA loop.
Going here and you're
The dura open. Fifth nerve.
Fifth nerve here. ICA.
Right?
Oh, that is
So that is called a contralateral transmaxillary approach, again to the petrous part of temporal bone through the nasal cavity. There's a scenario. It's a live surgery. We are doing a meningioma. This is a sella, the carotid artery. You're working behind the carotid artery, behind the petrous carotid artery. This is the clivus. So again, same anatomy. The fifth nerve, the 7, 8 there, the pre-op, post-op, right? And you already saw the transcochlear approach. I think it's time now for me to stop. And I think I covered pretty much in this 20 minutes given to me. So thank you once again for this wonderful opportunity. And if there is some doubt, you can put it in the chat box. Or you can ask it through the forum. Thank you once again. And I hope Dr. Karthikeyan would now go to the translabyrinthine approach.
Thanks, Professor Felix.
Yeah.
Thanks for your explanation of all middle cranial fossa. And will we take the question for now or end of the session, Professor Ahmed?
If we have time, we can take some questions for 5 minutes. I think it will be good.
Okay. I think Sabino, do you want to say something?
No, there's some question I can answer that. Probably you can also put it in the chat box.
Okay, but I don't see anything in chat box.
Yes. Then
If
probably
there
then
are questions,
probably
maybe you can
talk.
start with it.
We can go to the next talk then probably.
Okay, we can pass the next topic up. Professor Kateran, he will talk about the surgical anatomy of the translabyrinthine approach. Please, Professor, you can share your screen.
Good evening, one and all. It's a pleasure to meet you in this nice evening. Dr. Vinod Felix has made my job a bit easier, but mine is mainly through the lateral approach, the translabyrinthine approach. I hope you are all able to see the screen, my screen.
Yes, but not in the slide mode.
Okay, 1 second.
Yes.
Is it okay?
Yes. Perfect.
Okay. A brief introduction about me. I did a fellowship, lateral skull-based fellowship under Professor Sana in Italy, where they predominantly do acoustic neuroma lateral skull-based work. So without wasting much, let's go directly into the translabyrinthine approach. This approach is mainly used for tumors of the CP angle, the acoustic neuroma, the meningiomas, and the epidermoid cysts. So much of the tumors can be, the tumors of the CP angle can be removed through this approach. And of course, as Dr. Vinod Felix told, bigger tumors can be increased by extending this translabyrinthine approach a bit anteriorly. So going mainly this presentation, I'll deal about the surgical anatomy of the approach. This approach mainly centers around the facial nerve. So dealing with the facial nerve, the proper anatomy is of paramount importance in giving appropriate result in this approach. So in this approach, we first delineate first we do a complete mastectomy. Here, are you able to see this thing? My cursor which is moving?
Yes, we can see it.
Yeah, this is the left side here, where the middle cranial fossa, the sigmoid sinus, and this is the anterior, and this is the posterior. Here you can see the canal wall is intact, and the facial nerve is being delineated, and the labyrinth is being skeletonized, which is this is the lateral semicircular canal, this is the superior semicircular canal, this is the posterior semicircular canal. In this approach, we then we progressively keep removing the labyrinth, and sequentially, when we remove the labyrinth, we should keep in mind the essential structures which lie beneath the labyrinth. So on progressive skeletonizing, this is the ampulla of the superior semicircular canal. This is the posterior semicircular canal. This is the lateral semicircular canal ampullas. So the knowledge of the ampullas with relation to the facial nerve is very important, so that adequate preservation of the facial nerve is taken care of. For example, in the ampulla of the lateral semicircular canal, the facial nerve lies just 1 millimeter anterior to the horizontal segment of the facial nerve, and the superior semicircular canal also lies very close to the facial nerve. And the relation of the posterior semicircular canal is about 1 millimeter to the mastoid segment of the facial nerve. And one thing we have to be careful is that sometimes while removing the tumor, the jugular bulb might become very high. In that case, we should be very careful not to injure the jugular bulb. If in case we encounter a jugular bulb which is very high, we can just compress the jugular bulb with the help of bone wax, so that it stays away from the operating field. It is very important that we don't injure the jugular bulb, because any injury might lead to improper bloody field, and the procedure might take delay due to these things. And on progressive skeletonization, you create a trough between the you create a trough between the superior and the inferior portions of the internal aortic canal. After destroying all the labyrinth, you get the vestibule. All the semicircular canals converge into the vestibule. You create progressive troughs above and below the vestibule. So you delineate the internal auditory canal. When we in the inferior portion, you get the cochlear aqueduct. The cochlear aqueduct is important in that when we decompress that, the CSF will become, when we open it, the CSF will become will gush out, so that we decompress and we create a field, so that there is not much buoyancy of the CSF, so that working in the field will be easier. And also anterior to the cochlear aqueduct is the lower cranial nerves. So this forms the anterior limit of the this thing approach, translabyrinthine approach. Here you can see the internal auditory canal being delineated. And this is on progressively removing everything, the superior and the inferior troughs. you get to see the internal aortic canal, which is about a 1 centimeter canal, which is lined by dura. And this internal aortic canal is in parallel to the almost in parallel orientation to the external aortic canal. So this is the dura of the internal aortic canal. Here you can see the horizontal crest, which divides the internal aortic canal into superior and inferior compartments. Like Dr. Vinod told, this is the superior ampullary nerve, which is the continuation of the superior vestibular nerve. This plays an important role in preventing the injury to the facial nerve, which lies beneath. So on progressive skeletonization, here you can see the superior vestibular nerve, the superior ampullary nerve, the vestibule, the inferior vestibular nerve, and at the level of the fundus levels. So nowadays, we don't follow the previously used landmark, which is the Bill's bar, because on searching the Bill's bar itself, on searching the landmark itself, we can injure the facial nerve. So we follow the superior ampullary nerve, which is a continuation of the superior vestibular nerve. When we reflect the superior vestibular nerve, the facial nerve lies immediately beneath the superior ampullary nerve. Here you can see the superior ampullary nerve and the facial nerve below. This is the Bill's bar, which I told, the superior ampullary nerve being reflected and the facial nerve going in a lateral direction. So this is the arrangement of the nerves in the internal aortic canal, where you can see the horizontal crest or the falciform crest, the superior vestibular nerve, below which is the facial nerve, the inferior vestibular nerve, and below which is the cochlear nerve. So once when we remove the, once after skeletonizing the internal aortic canal, after removal of the dura of the cerebellopontine angle, the structures what we see are the, you can see a beautiful picture of the CP angle with a lot of essential structures crowded, and a very important knowledge of all this anatomy is important in preserving the structures and the careful removal of the tumor. Here on opening the on opening this dura, what you see immediately is the very thick nerve, which is the trigeminal nerve, and the artery, which is in close association with the trigeminal nerve, is the superior cerebellar artery, which is a branch of the basilar artery, and the acousticofacial bundle right in front of you. The facial nerve lies behind the acousticofacial bundle, and the artery which lies in close relation with the acousticofacial bundle is the anterior-inferior cerebellar artery, which is a branch of the basilar artery again. And going below, if we widen the approach, we can encounter the lower cranial nerves, the 9th, 10th, 11th complex, along with the postero-inferior cerebellar artery, which is a branch of the vertebral artery. So these are other pictures, what you can see, the acousticofacial bundle. And this is when we go, depending on the size of the tumor, you can widen the approach in the translabyrinthine approach. So this is another picture. And in case of a larger size of tumors, you can increase the size of the approach by, in the translabyrinthine approach, we have to, the essential difference is we have to maintain the posterior canal wall in a translabyrinthine approach. But if you want to widen the approach, there is an approach called transcochlear, where we remove the posterior meatal wall, and very large anterior reaching tumors can be removed by this kind of by extending this approach, is the transcochlear approach. The essential steps being the same, except that you reroute the facial nerve. This is the mastoid segment of the facial nerve. This is the internal aortic canal being delineated. What you do is excise the greater superficial petrosal nerve, and you do a posterior rerouting. After you do a posterior rerouting, much of the petrous bone is entirely under your control. For example, it's a very large corridor you can reach. So large size acoustic neuromas, like more than 3 centimeter large epidermal tumors anteriorly reaching, can be very well removed by this tumor. For example, this is the approach with the transcochlear, where you can reach far anteriorly. As Dr. Vinod sir told, you can reach the basilar artery as well as the clivus. Far anterior reaching tumors can be removed with this approach. First, you have to take control of the internal carotid artery, and after that, you can go far anteriorly, and any size of the tumor can be removed with this approach. So this is in brief about the surgical anatomy, which we have to know, and any surgery is about anatomy. So an essential knowledge of the anatomy is very important in proper removal of the surgical pathology. Thank you for giving me the opportunity. And any questions I would like to. Any doubts, any questions I would like to answer?
I think there is no question in the chat box. Any question from the audience? Okay. Professor
Thank
Sabino.
you. Thank you so much. I was not able to unmute me. Thank you so much. Just a couple of comments, and I have questions to my colleagues. And congratulations for the wonderful presentation. I do believe that trans-petrous approaches are still a land for neurosurgery and for neurosurgical and not on neurosurgical arguments. So what do you think about? In my experience, I always the best way to increase the exposure at the infralabyrinthine area, it's always, in my idea, necessary to sacrifice and to cut and coagulate the endolymphatic sac. Otherwise, you cannot retract the dura and you cannot expose the Trautmann triangle and the pre-sigmoid dura. What do you think about? Do you have experience in coagulating and sacrifice the endolymphatic sac? This is a trick for young neurosurgeon because, it's the only way to fully expose the infralabyrinthine area and also the jugular bulb. And if you see very well the apex of the jugular bulb, you decrease the possibility to, damage the jugular bulb, especially in those cases where the jugular bulb is very, very high. That could be even sometimes a relative contraindication to translab approach and trans-petrous approach. Do you have any experience?
Yes, sir. Like if there is a very high jugular bulb, most of the high jugular bulbs can be decompressed with the help of this thing. You have to unroof the jugular bulb. You have to skeletonize the jugular bulb, and you have to, with the help of a bone wax, sequentially compress so that it goes away from your field. And one case where where it is contraindicated beforehand itself is the if the pathology is in the dominant jugular bulb, then you might have to be very careful about that one, dealing with the sigmoid sinus of that area. So
yeah, I totally agree with you. And there were also a couple of comments. So retrolab approach, so the pure retrolabyrinthine approach in neurosurgery is very small indication because it's very narrow at corridor. So in most of the cases, it's should be considered a sort of a pure otologic approach because you can approach only for small cholesteatomas there with the retrolab approach. In most of the cases, we combine the retrolab approach with the subtemporal approach in what we usually refer as the combined petrosal approach. That practically speaking, it's an approach that totally spares the labyrinthine block. So it's the patient will not lose the hearing. And this kind of approach is very useful, especially for petroclival junction pathology, especially for petroclival junction meningioma in most of the cases, and some also aneurysm. And another consideration about the transcochlear approach. Transcochlear approach is a beautiful approach. It's the maximization of the exposure, but you have to pay the price always, not only about the deafness, because, you destroy everything, you destroy the labyrinth, but also when we talk about rerouting of the facial nerve in the both, especially transotic approach, is not different concept. In the pure transcochlear approach, for sure you pay the price of losing the facial nerve. Why? Because you have to take into account that with these approaches, you will have an Haus-Brackmann grade 5 postoperative most of the cases. First, because, if you touch the facial nerve, you devascularize the facial nerve because it's a source of vascular supply. So you have to take careful, and you have to take into account that these approaches are a little bit aggressive and destructive in most of the cases. So the true indication in the common, in the common practice, in the daily practice, as for huge, giant paragangliomas with the involvement and encasement of the vitreous carotid and something like that. In most of the cases, translab approach is a beautiful approach in those cases of for example, giant vestibular schwannoma, especially when they reach the fundus of the meatus, and the patient have what we call the non-serviceable hearing. So it means that the patient already lost the hearing. So just for orientate for young neurosurgeon, these are the extremes measure in terms of very small and very huge, but we stay in the middle in most of the cases in the translab approach. But anyway, I want to thank you so much for the beautiful quality of your picture and presentation, because this is one of the most challenging and complex topic and approaches within the lateral skull base. Thank you. Thank you so much.
Thank you. Thank you.
If there's no more questions, I will start my topic. Firstly, I would like to thank the previous lecturers because they're more familiar from us these anatomy, the temporal bone and the labyrinth and the ear. Thanks for their good explanation. My presentation will be short because they explained most of the things. I will give some information about middle cranial fossa and cavernous sinus. Then I will show a video about one trigeminal schwannoma. Firstly, I don't have anything to declare, but I have a big team behind me, and also I would like to thank these Hussein, Sardar, Mustafa, and the Professor Ture to help me for this presentation. We are looking from the superior to skull base, the anterior skull base, middle skull base, and posterior. As you see, also you must know the middle cranial fossa anatomy, to which the pathology is located in the middle cranial fossa. Also, you can reach pathologies like basilar artery, posterior cerebral artery, brainstem pathologies through the middle cranial fossa. Because of these, neurosurgeons must be familiar to this anatomy. And we are looking from the from lateral to medial. You can see all structures related with the middle cranial fossa, fifth nerve, fourth nerve, third nerve, second nerve, and carotids, petrous carotids, brainstem, and the branch of the P2, and also the anatomy of ear, middle ear, internal acoustic canal explained from the previous lectures. Firstly, cavernous sinus. As you know, there's two layers. It has two layers, and the nerves like the third nerve, fourth nerve, and the ophthalmic and maxillary nerve located lateral, and afferents nerve located medial to the cavernous sinus. And which the veins drain into the cavernous sinus. As you see, it is very complicated. Because of these, neurosurgeons always a bit afraid of to touch cavernous sinus because most of the time there's no problem, but if any problem about this flow, it can be serious. Because of this, it is better to know there are a lot of veins draining in the cavernous sinus. It is a bit difficult to know all these veins, like the inferior ophthalmic, superior ophthalmic veins, and the other ones also. And we will look to middle cranial fossa today. Firstly, this is the temporal fossa dura. All structures hidden by these fossa. Step by step, we will remove all layers and see what is hidden inside it. As you see, after removing the dura, you can see the artery of the fifth nerve and its branch, and also you can see the fourth nerve, third nerve, and also there are related structure like the carotids and the second nerve and the sella. And when we remove artery of the fifth nerve, you can see the branch of the fifth nerve, the ophthalmic, maxilla, and mandibular plans. Also, you can see GSPN. As you see, just under this nerve, you can reach the cavernous sinus here. As you see, these nerves located lateral to the cavernous sinus. This is third nerve, fourth nerve, and the ophthalmic and the maxillary nerve, first and second branch of the fifth nerve. And we remove the cavernous sinus, you can reach the, you can see the carotids here. And when we retract the fifth nerve, the sixth nerve, it is hidden under the fifth nerve. You can see its trajectory. Also, you can see you can reach to the inferior temporal fossa with removing the bone under the fifth nerve. And we are looking from the posterior to anterior to see cavernous sinus and related structures. As you see, this is the cavernous sinus, and this is sixth nerve located medial to the cavernous sinus, and the nerves which are located to the lateral to the cavernous sinus. This is the maxillary nerve, ophthalmic nerve, and the fourth nerve, and the third nerve located there. This is the fourth and the third nerve located the lateral to the cavernous sinus. And this is the cavernous carotid artery segment. We are looking from the a bit superior to get a good view. After removing all venous structures, you can see carotids and its branch, the inferior hypophyseal branch and superior hypophyseal branch, and also its relation with the nerves. We are looking to a bit macroscopic view to see the branch of the cavernous carotid segment. As you see, we remove the bone and to show the carotids and its segments to the temporal bone. And the anterior clinoid purchase, if you remove the anterior clinoid purchase, you can have access to carotid artery. Most of the time we use also middle fossa approach to get a good view. And this is the view if we remove all structures and the fifth nerve. You can see the carotids, cavernous sinus, lateral wall, and the carotids. And also this is the 3D models to show middle fossa anatomy and its related structures. We are coming closer. This is the middle fossa, and you can see the fifth nerve here, cavernous sinus located just anterior to middle fossa. You can see the other structures like the third nerve. You can see all structures here related to the middle cranial fossa, third nerve, ophthalmic nerve, fourth nerve, ganglion, and the petrolingual ligament. And also, we are looking at the segment of the carotis artery. This is the anterior clinoid porches, and removed to see the carotis artery. And you can see the distal dual wing and posterior dual wing, and also cellular lesion. And also, we are looking from the same area to show the related structures and the brainstem located here, and all structures related with the cavernous sinus. And also we use some triangles to reach lesions located in specific areas. As you see, there are a lot of triangles which you can use in neurosurgical practice. I will show some of them. This is the clinoidal triangle, which you can reach after removing the anterior clinoid porches, and also oculomotor triangle. It is located to medial to the oculomotor to the carotis, and supratrochlear. It's located between trochlear and third nerve and the infratrochlear nerve. And it is located between the trochlear nerve and the ophthalmic branch of the fifth nerve, and also anteromedial triangle located in the ophthalmic and the maxillary branch of the fifth nerve, and anterolateral triangle located between the maxillary and mandibular branch of the fifth nerve, and also Glasgow triangle located posterior to the
باقي شوية.
also the Kawase triangle located to posterior to the fifth nerve and medial to the GSPN. Most of the time we use this angle to reach structures located in the middle fossa and posterior fossa. And also it is always easy to see structures hidden in posterior fossa when you use this way to complicated trigeminal schwannomas, and because you can see the residual tumors if you use endoscope. And this is the case of trigeminal schwannoma, and also located in the cavernous sinus, as you see, and you can see the carotis. Yeah, it is difficult cases, but if you know the anatomy and if you should behave gentle, you can do this kind of surgeries. This is the Dolenk approach. We open the middle cranial fossa and reach the Meckel cave, and with pteronal transsylvian approach, and also under the temporal pretemporal approach also you can say. As you see, after pteronal craniotomy, firstly you see the meningoorbital band, and after because without cutting this band you couldn't retract and reach the area. And after cutting, you can peel the inner layer of the dura to reach the fifth nerve and the branch. And also to retract, you can put some sutures for retraction sutures. And as you see, after retraction, you can see the tumor. And start to remove the tumor between the branch of the V2. As you see, in a piecemeal session, it is being removed. Also, with Doppler ultrasound, you can check the localization of the carotids during the operation. As you see, we always use gentle movements. And we reach the posterior cranial fossa and keep removing the tumor. And also you can see branch of the fifth nerve. We try to preserve all branches, which we can. Then we are removing the tumors inside the cavernous sinus. And we are checking with the endoscope to see any residual or tumor. As you see, we put the endoscope on here. And you can see the fifth nerve and the postoperative view. And closing, we always put some sponge gel to the area. This is the postoperative waves. And this is our laboratory in Yeditepe University. I'm working with the Professor Uğur. And also this is our laboratory. Also I'm here with our team now. We have an archive, and also I was to take photos and the working stations and the wet lab. We have 5 microscopes now. We have 11 fellows, and also we published several papers about the 3D models of the white matter dissection. You can reach via Neurosurgical Atlas to our dissections, which is performed in our laboratory. You can reach 2D photos, 3D photos, and 3D models with labels. And I think it is easier to learn anatomy with these models, as you see. And also we try to publish our better models for now. You can see the every detail about the brain anatomy. And also we are trying to establish our virtual neuroanatomy laboratory. In the future, I think we will talk anatomy within these virtual laboratories with your VR glasses. Thanks for listening.
Thank you very much, Doctor, for this nice presentation. And thanks to all the speakers. We'll see if there is any questions.
I think Sabina will say something.
I just have to congratulate Professor Güngör for this beautiful, always astonishing presentation, because he showed us everything and the key technical step for most of 100% of middle and anterior skull base approaches. And I totally agree with him about the fact that it's critical to cut the meningorbital band before to perform anterior clinoidectomy, because it's the only trick, it's the pure most important trick to totally retract the dura in the peeling of the lateral wall of the cavernous sinus, just a little bit to expose the tip of the anterior clinoid process. It's a beautiful trick, because you must do it every time you have to perform, because otherwise you risk to injure not only the optical strap, and you are working very close to the internal carotid artery. So it's a beautiful trick. I totally agree with him. And congratulations once again for this beautiful, beautiful, beautiful presentation. Thank you.
Any question from the audience or any comments? Nagiza, do you want to add anything? Okay.
Hello,
There is
everyone.
okay.
Thank you very much for all speakers for the nice presentation. For all young neurosurgeons, it will be very helpful. I have one question to Professor Vinod Felix. Sir, if you're here. So I had a great chance to work with Sir in India. So the question is, when do you decide to go for combined approach? If you could explain for young neurosurgeons. So is it depend on the type of the tumor or the size of the tumor or involving of the carotid artery? You mentioned in one case that you went for combined approach. One was transnasal and another one's transaortic. Thank you.
Nargis, it's actually a pleasure to hear from you again. So it basically depends on the tumor extent. The tumor extent and the hearing is preserved, the facial nerve status. So all this needs to be considered when you plan a combined approach. For example, if you have a tumor in the clivus going to the petrous body, the hearing is preserved, I would come transnasal, I would mobilize the entire carotid artery, or would consider doing a contralateral transmaxillary approach to remove the petrous body tumor. But if the hearing is already gone and the facial nerve is affected, I would come transcochlear, because with the microscope have better control of the tumor than coming with the endoscopic approach.
Thank you, sir.
My only point is the risk of CSF fistula approaching, the petroclival junction. This is what they call, front door of the Meckel's cave. It's nice approach from the anatomical point of view, but in clinical practice, it's very, very risky for CSF fistula. Do you have any experience of management of fistula when you approach that region by endoscopic route, I mean?
Now, are you asking about the contralateral transmaxillary approach or the
contralateral or ipsilateral, whatever you want. Ipsilateral, it's the same.
Transnasal approach.
Yeah.
Now, the CSF leak occurrence is pretty low in our center, because see, we have been doing it routinely, but if you are doing it like once in a while, you may have to struggle with the CSF leak, because it basically depends on your close-up techniques. Once you have some vascularized flap, the leak rates are pretty low, actually.
What do you use to reconstruct the dural defect when you approach that kind of lesion by transnasal, transmaxillary? See, what do you use? Flat graft?
When we come through,
you don't have a dead flap there, for sure. To the best of my knowledge, you don't have a dead flap. So
we have the Haddad flap. We have the Haddad flap. We have the.
You have a dead flap?
Yeah. We have the Haddad flap from the same side.
You can turn laterally and okay.
Yes, we can do two things. One, we can take the flap from the same side of lesion. And suppose you don't have the flap on the same side, you have to do something called the mobilization of the flap with the pterygopaline fossa. On the other side, contralateral side, we can take the flap, we can mobilize the flap with the maxillary artery along with the pterygopaline fossa, and go through the contralateral.
Does it work? Does it work in that region? Yes or no?
Yes.
Does it work in your experience?
It works very well. Actually, it's very easy to close the contralateral transmaxillary window, because the actual window is pretty small. The bony osteotomy behind the carotid is very small. It appears bigger because we are having that particular view from the maxilla. Otherwise, the opening is pretty small. It is actually much more difficult to close a transclival defect or a suprasellar meningioma than the contralateral transmaxillary approach.
I trust you.
Sure,
Thank you.
Actually, yeah.
Sure. Thank you so much. Thank you.
Thank you.
I am checking the chat box. I think most of the audience liked our presentation and they sent their regards to all lecturers. And if there's no more comments and questions, I want to thank all lecturers and the audience. I think, Ahmet, can you give the information for the next meetings?
Okay, sure. Next session will be next Friday at the same time. Let me just check from the schedule. Okay. Okay. So next we have 3 presentations. First will be with Dr. Eduardo Rabes about brain meninges anatomy. And the second will be with Dr. Maximiliano Nunes about dural venous sinuses anatomy. And the last will be with Dr. Abid Shah, who will take about the cavernous sinus anatomy. So I think
yeah, I think it will be great. I couldn't wait to see these presentations. I think we can close the session and webinar. I want to thank again to all audience and lecturers. See you next week.
thank you very much. Thank you for all attendance and for all speakers.
Thank you all.
And see you all next week, inshallah.